Hello listeners, this is Dr. Adam Wilson again. In this session we're going to take a look at the middle mediastinum, which contains both the pericardium and the heart, and then we're going to take a very detailed look at the heart specifically. The mediastinum is the centralized compartment of the thorax, positioned between the two pulmonary cavities, represented here by the X's. The pulmonary cavities are also referred to as pleural cavities. The purple filling these cavities represents the lungs. The mediastinum extends from the superior thoracic aperture above to the inferior thoracic aperture below, which, as you may recall, is bound by the diaphragm. Anteriorly, the mediastinum is bound by both the sternum and the costal cartilages, and posteriorly it is bound by the thoracic vertebrae. As a review, the sternal angle of Lewy marks the level of the transverse thoracic plane, abbreviated here TTP. Conceptually, the transverse thoracic plane divides the mediastinum into a superior mediastinum above and an inferior mediastinum below. The inferior mediastinum is then further divided into an anterior mediastinum, which lives between the sternum and the pericardium. There's also a middle mediastinum, which contains the pericardium and the heart. And then behind the pericardium is the posterior mediastinum, positioned between the posterior aspect of the pericardium and heart, and bound posteriorly by the thoracic vertebrae. Within the posterior mediastinum, you'll find the esophagus and the descending thoracic aorta. Realize that the mediastinum is a highly mobile region. Not only is the heart beating, but the great vessels are pulsating, and at mealtime the esophagus transmits a bolus of food through the posterior mediastinum. Not only that, but during respiration, as the diaphragm contracts, the pericardium and the heart move down with it. The pericardium is the tough fibrous membrane that encases the heart. It is made up of two layers, the fibrous pericardium and the serous pericardium. The very durable fibrous pericardium is the outermost layer that is continuous superiorly with the adventitia of the great vessels, as shown here. Inferiorly, the fibrous pericardium blends with the central tendon of the diaphragm, as shown here on the left, and as shown here on the right. The site of continuity between the fibrous pericardium and the diaphragm is referred to as the pericardiacophrenic ligament. Hence, when the diaphragm contracts, it brings the pericardium and the heart downward with it. The toughness and rigidity of the fibrous pericardium is thought to prevent the heart from overdilating when it fills with blood. As you will appreciate in lab, the internal surface of the pericardium is lined with a shiny serous membrane called the parietal pericardium. The cells of this membrane secrete serous fluid into the pericardial cavity to create a nearly frictionless environment for the beating heart. Let's dwell for a moment on the difference between the parietal and visceral serous pericardium. During development, as the heart expands into the pericardial cavity, it takes on part of the pericardium, and that pericardium is referred to as the visceral pericardium, which immediately surrounds the heart. The pericardium which continues to line the pericardial cavity is referred to as the parietal pericardium. Between the visceral and parietal pericardium lives the pericardial cavity. And again, this cavity is filled with serous fluid to create a frictionless environment for the beating heart. Here's a slightly different view of the pericardium. Notice the outermost layer is the fibrous pericardium, which is very rigid and tough. Lying just deep to that is the parietal layer, and then lying on the surface of the heart itself is the visceral layer of pericardium. Notice the visceral layer of pericardium is the outer surface of the wall of the heart itself. Therefore, it is also called the epicardium of the heart. The thickest portion of the heart wall is the myocardium, which is made up of cardiac muscle, and the innermost lining of the heart is the endocardium. From this slide, I simply want you to remember that the words epicardium and visceral layer of serous pericardium are interchangeable. The pericardium is supplied with blood via the pericardiacophrenic vessels, as shown here. These vessels are small branches that arise from the internal thoracic artery and drain back into the internal thoracic vein. These vessels are going to course in company with the phrenic nerve. The small branches of the phrenic nerve, which are going to supply the pericardium as well, will contain general somatic afferent fibers, which are sensory fibers that will convey information about pain from the pericardium. Pain is going to be transmitted through the branches of the phrenic nerve, back to the phrenic nerve, and back to the levels C3, C4, and C5. Pericardial pain could be the result of pericarditis, which is inflammation of the pericardium, or it could be the result of a more severe condition, such as a cardiac tamponade. When an excess of fluid builds within the pericardial cavity, it is termed a pericardial effusion, which can be caused by pericarditis or congestive heart failure, for example. As the pressure from the pericardial effusion builds within the confines of the fibrous inelastic pericardial sac, the fluid, with nowhere to go, begins to compress the heart in a condition known as a cardiac tamponade. Cardiac tamponades can be lethal because the heart volume and cardiac output are increasingly compromised as the condition worsens. And so to correct this emergent condition requires that the pericardial cavity be drained of the accumulating fluid. A pericardiocentesis is performed in which a needle is inserted, which is attached to a syringe, into the pericardial cavity. And under ultrasound guidance, once the needle enters the pericardial cavity, the plunger is withdrawn in order to remove the fluid from the pericardial cavity. A common approach to this pericardiocentesis is a subxiphoid approach, meaning that the needle is angled toward the left shoulder and is placed just underneath the xiphoid process on its approach to entering the pericardial cavity. Once the cavity is drained of the excess fluid, the patient feels relief almost immediately. In this image, the thoracic wall has been superimposed over top of the heart so that you can better appreciate the relationships of the thoracic wall and the heart itself. Let me first bring to your attention two intercostal spaces. The second intercostal space on both sides of the sternum are a prime location for auscultating heart valves. Additionally, the fifth intercostal space is also a prime location for auscultating heart valves. Please note, however, that the illustrator made a mistake in this illustration. The level of the nipple is actually at about the fourth intercostal space, not the fifth intercostal space. Notice that about 2/3 of the heart resides just to the left of the midline and the sternum. This area of the heart here at the fifth intercostal space is the apex of the heart. If you think of the heart as a pyramid in shape, think of that pyramid as lying flat on its side, with the base of the heart in the posterior direction. The apex then represents the pinnacle of that pyramid. Whenever you visualize the heart on chest x-ray, the majority of the heart that you're seeing is going to be the right ventricle. Likewise, you can also see a small portion of the right atrium slipping out from the right edge of the sternum. And just above the right atrium, you can also appreciate a sliver of the superior vena cava. To a lesser extent, the aortic arch and the pulmonary trunk will also be visible upon chest x-ray. So now let's translate some of the information on this image to a real chest x-ray. Here's the heart in situ as visualized through a chest x-ray. The heart from this perspective is often referred to as the cardiac shadow or cardiac silhouette. Plain chest radiographs can be taken from two views, called an AP view or a PA view. The PA view stands for posterior-anterior view, and the AP view stands for anterior-posterior view. These views simply represent the direction the X-ray beams are passing through the patient. No matter the approach used, you will always interpret and review a chest X-ray as if you are standing and looking at the patient and the patient is looking back at you. That means that this represents the right side of the patient and this represents the left side. Notice that in the midline, the heart shadow is obscured by the dense sternum, which appears very bright white on the chest X-ray. However, to the sides of the sternum, you can still visualize several structures. For example, this structure appearing at the right sternal margin represents the superior vena cava. Similarly, this structure in blue is the inferior vena cava entering the thorax through the caval opening. The area between these two vessels, represented here in purple, would therefore represent the right atrium. Here in orange is the right ventricle. Recognize that the majority of the heart from the anterior view consists of both the right ventricle and the right atrium. Behind the manubrium, the aortic arch can be visualized, and you can also see it emerging from the left-hand side of the sternum. And you can also see a sliver of the pulmonary trunk and the left pulmonary artery. The area represented by yellow is the left ventricle, and here is the left auricle. While on this image, I also want to point out that the left hemidiaphragm is positioned lower than the right hemidiaphragm. Here's the right hemidiaphragm, and here's the left. The right hemidiaphragm sits higher within the thoracic cavity due to the fact that the liver is situated just below it, and it pushes the right hemidiaphragm superiorly. The left hemidiaphragm contains the stomach just underneath of it. On chest x-ray, you can often see a gastric bubble shown right here in the fundus of the stomach. And lastly, I'll point out that we are looking at a female patient, as you can see the contours of the breasts outlined here. Before describing the external and internal features of the heart, I first want to describe blood flow through the heart. There are 4 routes through which oxygen-depleted blood can enter the right atrium. The greatest volume of blood enters the right atrium through 2 major vessels, the superior vena cava and the inferior vena cava. The superior vena cava will drain the head, the neck, the upper limbs, and the thorax. The inferior vena cava is the major conduit through which blood passes that is being returned from the abdomen and the lower limbs. The coronary sinus, along with the cardiac veins, will return blood from the heart itself to the right atrium. Once in the right atrium, blood flows through the right atrioventricular orifice, represented by the oval, into the right ventricle. And from the right ventricle, blood is transmitted through the pulmonary trunk, which divides into the left and the right pulmonary arteries. These pulmonary arteries transmit blood to the lungs for replenishment. Blood is returned from the lungs to the left atrium via the pulmonary veins, of which there are 4. Blood passes into the left ventricle through the left atrioventricular orifice, guarded by the mitral valve, and from the left ventricle, blood is shunted upward into the ascending aorta, which transitions very quickly into the aortic arch. Blood from this point will be distributed systemically. Over the next series of slides, we're going to identify the structures of the heart. As I reveal each label, I'll give you a brief description of each structure. The largest and thickest of the great vessels that emerges from the heart is the ascending aorta, which quickly transitions into the aortic arch at the transverse thoracic plane. The ascending aorta receives blood that is pumped from the left ventricle of the heart, and it carries that blood systemically to the rest of the body. Embryologically, the ascending aorta is going to be derived from the truncus arteriosus. The right auricle, as its name suggests, is an ear-like appendage of the right atrium. Internally, it is a conical muscular pouch that increases the volume or capacity of the right atrium. The furrow at the lower edge of the auricle is the right coronary sulcus, or groove. Running within the coronary sulcus at this location is the right coronary artery. This external groove also marks the separation of the right atrium above from the right ventricle below. The right margin of the heart is an obliquely oriented edge formed mostly by the right ventricle. Along this margin is where you'll locate the marginal artery, which comes from the right coronary artery. More on that in a moment. The anterior interventricular sulcus is an external groove over top of the interventricular septum, which internally divides the right from the left ventricle. As you'll learn in a moment, a very important artery and vein reside in this groove. The apex is the tip of the heart that is located at the 5th intercostal space just lateral to the sternum. Again, this is a good site for auscultation. From this anterior viewpoint, only a small portion of the left ventricle is actually visible. The majority of the anterior heart is consisting of the right ventricle and the right atrium. There is also a left auricle that projects from the left atrium. And lastly, the pulmonary trunk conveys blood from the right ventricle to the lungs through the pulmonary arteries. Again, the pulmonary trunk will be carrying oxygen-depleted blood to the lungs for replenishment. By rotating the heart, several other structures now come into view. Here are the left and right pulmonary arteries coming from the pulmonary trunk heading towards the lungs. Notice how the aortic arch courses over top of the right pulmonary artery. And here are the four pulmonary veins entering the left atrium, which forms the base of the heart. Again, if you think of the heart as being pyramid-shaped, it's like a pyramid lying on its side. Hence, the base of the heart is not in contact with the diaphragm, but is actually positioned posteriorly facing the thoracic vertebrae. The coronary sinus is a large vein that encircles the posterior aspect of the heart. The cardiac veins, which come from the heart itself and drain the heart, are going to feed into the coronary sinus, which will then empty into the right atrium. The inferior vena cava and superior vena cava are the large collecting veins that return blood to the right atrium. The inferior vena cava returns blood from the abdomen and lower limbs, while the superior vena cava returns blood from the thorax, upper limbs, as well as the head and neck. In this posterior view, the heart has been tilted upward for a better look at the inferior heart wall, also called the diaphragmatic surface. Recognize that more of the left ventricle rests on the surface of the diaphragm than does the right ventricle. The posterior interventricular sulcus is the external groove that marks the posterior separation between the right and the left ventricles. There is another artery-vein pair that runs within this sulcus. Again, more on that in a moment. Now let's peer inside of the right atrium. The large vein entering at the superior posterior aspect of the right atrium is the superior vena cava. The smooth partition dividing the two atria is the interatrial septum. Embryologically, the septum is formed from the septum primum and the septum secundum. At the inferior aspect of the interatrial septum, there is an oval thumbprint-sized depression called the fossa ovalis. This depression is a remnant of the foramen ovale in the fetus. Before moving on, I want you to recognize that there are several differences between fetal circulation and adult circulation. One difference is the presence of the foramen ovale in the interatrial septum of the fetus, represented here by the green circle. Because the lungs of the fetus are not functioning, and because the fetus rejuvenates its blood supply through the mother via the placenta, there is no need for large volumes of blood to circulate through the pulmonary circuit. Therefore, the opening in the interatrial septum, called the foramen ovale, allows the majority of oxygen-rich blood from the placenta to be shunted directly to the left atrium. This allows the blood to bypass the lungs so that it can be immediately sent out for systemic circulation. At birth, when the baby takes its first breath, the lungs expand with air, and the pressure changes within the atria force the foramen ovale closed. It then fuses with the interatrial septum to leave behind a thumbprint-sized depression called the fossa ovalis. Now, on occasion, the fusion does not occur, leaving behind a patent foramen ovale, which actually allows oxygen-depleted blood from the right atrium to spill into the left atrium. In the case of fetal circulation, for the blood that does make it into the pulmonary trunk, there is a second shunt that will move the blood away from the lungs. This shunt is called the ductus arteriosus. The ductus arteriosus redirects blood from the left pulmonary artery into the aortic arch. After birth, this ductus arteriosus collapses and leaves behind a remnant called the ligamentum arteriosum. Internally, as the inferior vena cava enters the right atrium, it has a valve, sometimes referred to as the eustachian valve, that in fetal development helps to direct blood flow towards the foramen ovale. The opening of the coronary sinus and its small valve, called the Thebesian valve, are located near the valve of the IVC along the floor of the inner atrial septum. Finding both the opening of the coronary sinus and the valve of the inferior vena cava will help to locate the fossa ovalis, which is just superior and posterior to these structures. The right atrioventricular orifice is the opening between the right atrium and the right ventricle. This particular orifice is closed by the tricuspid valve during ventricular contraction. The pectinate muscles are ridges of muscle in the anterior wall of the right atrium. Functionally, pectinate muscles help to expel residual blood from the atria during atrial systole. The pectinate muscles then terminate at a smooth ridge called the crista terminalis. The crista terminalis is an embryologic line of fusion between the primordial atrium and the sinus venarium that together form the entirety of the atrium. Running within the crista terminalis is an internodal pathway that is part of the conduction system of the heart. This internodal pathway allows for communication between the S8 node and the atrioventricular node. And lastly, just notice how the pectinate muscles tend to extend upward into the auricle. In this image, the anterior wall of the right ventricle has been removed. Superiorly, the right ventricle tapers into the smooth-walled conus arteriosus, which is also called the infundibulum. This area leads directly into the pulmonary trunk. The three cusps of the tricuspid valve are connected to the heartstrings, which are called the chordae tendineae. These heartstrings are in turn anchored to the papillary muscles. The anterior papillary muscle, shown here, anchors the anterior cusp of the tricuspid valve. Likewise, the septal papillary muscle anchors the septal cusp, and the posterior papillary muscle anchors the posterior cusp. At the start of ventricular contraction, the papillary muscles contract, putting tension on the chordae tendineae, and in turn, the tension on the chordae tendineae prevents the tricuspid valve from regurgitating or prolapsing upward into the right atrium. Recognize that these papillary muscles do not close the valve, but instead they prevent the valve from prolapsing through the chordae tendineae, because the chordae tendineae put tension on the leaflets. The function of heart valves in general help to maintain a one-way flow of blood through the heart. The interior of the right ventricle has irregular muscular elevations, collectively called the trabeculae carnae. One trabecula stands out among all the others, and this is the septomarginal trabecula, also called the moderator band. This moderator band bridges from the interventricular septum to the anterior papillary muscle. This particular trabecula is unique because running within it is part of the right bundle branch of the atrioventricular bundle, which is a component of the heart's conduction system. And lastly, the pulmonary semilunar valve is at the apex of the conus arteriosus. This valve prevents the backflow of blood into the right ventricle once blood has entered into the pulmonary trunk. The valve guarding the left atrioventricular orifice is the mitral valve, named because it resembles the mitre hat of a bishop, shown here. It is also referred to as the bicuspid valve. Just like the tricuspid valve on the right, the mitral valve prevents the backflow of blood from entering the left atrium during ventricular contractions. The remaining structures of the left atrium and the left ventricle are very similar to those of the right heart chambers. The only structure that appears in the left atrium, which does not appear in the right atrium, is the semilunar depression and valve of the foramen ovale. Everything else is the same. This particular valve allowed for the one-way flow of blood in fetal life from the right atrium to the left atrium. Again, the purpose of the foramen ovale was to bypass the lungs. The muscle fibers of the heart are anchored to the heart's fibrous skeleton, which is shown here in orange. As part of this fibrous framework, there are dense collagen rings, called fibrous rings, that encircle the orifices of the four heart valves, and these rings act as attachment points for those valves. The fibrous skeleton keeps the orifices of the heart valves patent, and it prevents overdistension by the increased volume of blood being pumped through each orifice. Additionally, the fibrous skeleton also acts as an electrical insulator, which allows the atria to contract independently of the ventricles. In the view on the right of the screen, we are looking down at the top of the heart. The atria have been removed in order for us to visualize all four heart valves simultaneously. Here we see the two larger atrioventricular valves indicated by the X, and the two smaller semilunar valves indicated by the circles. As was previously described, the tricuspid valve has three cusps: an anterior cusp, a septal cusp, and a posterior cusp. The bicuspid valve has only two cusps, an anterior and posterior. Each of these semilunar valves is associated with three cusps. This is the pulmonary semilunar valve. The pulmonary semilunar valve has a left cusp, a right cusp, and an anterior cusp. Conversely, the aortic semilunar valve has a left cusp, right cusp, and a posterior cusp. The only difference is anterior versus posterior cusps. I remember that the anterior cusp is associated with the pulmonary semilunar valve because the pulmonary trunk is positioned anterior to the aorta. Or you can think of the aorta as being positioned posterior to the pulmonary trunk, therefore it has a posterior cusp. Do recognize that the atrioventricular valves are considered to be active valves because these valves rely on the contraction of the papillary muscles in order to hold the valves closed as the force of the blood is placed against them during ventricular contractions. These arrows here represent the force of the blood. Contraction of the papillary muscles puts tension on the chordae tendineae, and that tension prevents the cusp from prolapsing. In contrast, the semilunar valves are considered to be passive valves. This is because they do not require any muscular energy to hold them closed. The semilunar valves, consisting of the aortic and pulmonary semilunar valves, have three pouch-like cusps. As blood leaves the ventricles, the semilunar cusps are pressed against the walls of the vessel. When the ventricles begin to relax during ventricular diastole, residual blood within the vessel regurgitates toward the ventricles. The sinuses of the cusps fill with the backflow of blood, and the edges of the three cusps unite, preventing significant amounts of blood from being returned to the ventricles. The thickened edge of the cusps is called the lunule. The lunule creates a tight contact between the cusps to prevent a leaky valve. At the apex of each of the free edges of the cusp, there is a thickened nodule. These nodules, when they unite, help to prevent the prolapse of the semilunar valves. Because the heart beats approximately 100,000 times per day, heart valves are continuously in motion, and as we age, the integrity of these valves can become lost. The term valvular heart disease is an umbrella term for heart valve disorders that disrupt the pumping efficiency of the heart. Stenosis and insufficiency are two very common conditions. The word stenosis from the Greek means narrowing, so valvular stenosis is a narrowing of the heart valve from either calcifications or from scarring that forms on the valve leaflets. The photo at the bottom left of the screen shows severe aortic stenosis. As you can see, the cusps of the aortic valve have calcified and have become very rigid. As such, the amount of blood that can be conducted through the aorta has been cut in about half. Insufficiency, on the other hand, is very simply a leaky valve, in which blood regurgitates through the valve in the wrong direction. Both stenosis and insufficiency can cause heart murmurs, which can be detected through auscultation of the heart. Mitral valve prolapse is another fairly common condition in which the tension on the cusps of the mitral valve have become lax. During ventricular contraction, the cusp cannot withstand the force of the blood, and as such, the cusps are pushed upward into the left atrium. As you can imagine, this compromises the one-way flow of blood through the heart. In severe instances, patients with mitral valve prolapse may require valve replacement. One of the most basic skills learned by a physician is how to auscultate heart sounds, which are made by the closing of the valves. The key point to remember is that you always listen downstream of the valve. according to the flow of blood through the heart. Say, for example, you wanted to auscultate the tricuspid valve. To do so, you would place the bell of the stethoscope in the fifth intercostal space along the left margin of the sternum. Placement in this area allows you to hear blood as it flows through the right atrioventricular orifice. You already know that the right ventricle pumps blood through the pulmonary trunk, and so as blood moves upward through the pulmonary trunk, the best location to listen to the pulmonary semilunar valve is the left second intercostal space adjacent to the sternum. The mitral valve is best heard in the fifth intercostal space near the mid-clavicular line. As blood rushes through the left atrioventricular orifice, it takes a quick turn toward the apex of the heart, making this the prime location to pick up the mitral valve sound. As blood then rushes toward and through the aortic semilunar valve, the best location to auscultate the aortic semilunar valve is the second intercostal space on the right-hand side, adjacent to the sternum. The aortic semilunar valve is somewhat unique in that it has two small openings for the left and right coronary arteries. The coronary arteries will supply blood to the myocardium of the heart. As blood backflows, it fills the valve sinuses and closes the cusps, and some of the blood within those sinuses then drains through the coronary ostia into the coronary arteries, which will supply the heart with nutrients and oxygen. The right coronary artery originates from the ascending aorta, and it runs toward the right margin of the heart as it courses within the right coronary sulcus. One of the earliest branches to emerge from the right coronary artery is the sinuatrial nodal branch, abbreviated the SA nodal branch. In about 60% of cases, the sinuatrial nodal branch arises from the right coronary artery, and in about 40% of cases, it arises from the circumflex artery, which is a branch of the left coronary. At the right margin of the heart, the coronary artery sends off a small marginal artery that follows the right heart margin. This artery supplies the right ventricle. And what you don't appreciate from this particular viewpoint is that the right coronary artery continues around to the back of the heart to give rise to the posterior interventricular artery. We'll see a better view of that in just a moment. The left coronary artery arises posterior to the pulmonary trunk. It is relatively short because it quickly divides into two main branches. The circumflex artery circles toward the posterior heart beneath the left auricle to supply the left atrium and the lateral wall of the left ventricle. Coursing along the anterior interventricular sulcus is the anterior interventricular artery, also referred to as the left anterior descending artery, which is frequently abbreviated the LAD. This is the widowmaker. An occlusion of this artery, if left untreated, is life-threatening. The descriptive name of this vessel, which is the anterior interventricular artery, implies that it supplies the anterior two-thirds of the interventricular septum. In addition, it will also supply the anterior portions of the left and the right ventricular walls. From this view of the diaphragmatic surface, we see the circumflex artery sneaking around to supply the lateral wall of the left ventricle, and the branch to the SA node is here, coming up to supply the sinuatrial node. We also have a better view of the right coronary artery terminating as the posterior interventricular artery. The posterior interventricular artery runs along the inferior surface of the heart to supply the posterior one-third of the interventricular septum. It also supplies the posterior walls of the left and the right ventricles, and it gives off a branch to the atrioventricular node, which is involved in the heart's conduction system. If the posterior interventricular artery arises from the right coronary artery, the heart is considered to have a right dominant circulation. The areas in green are supplied by the right coronary artery. Right heart dominance is considered to occur in about 60 to 70% of the population. A left dominant heart is one in which the posterior interventricular artery arises from the left coronary artery, as seen here. More specifically, it would arise from the circumflex branch of the left coronary artery. Both left dominant circulation and codominant circulation are prevalent in the population at about 15%. Anatomically speaking, we would consider this to be normal variation. Clinically speaking, this could be important to know if you are conducting an intervention on the posterior interventricular artery because of an occlusion, for example. To discern whether or not a heart is right or left heart dominant would require an arteriogram. Now let's take a look at the cardiac veins which accompany the coronary arteries. The first veins to mention are the anterior cardiac veins. These are very small veins that run along the anterior surface of the right ventricle. They empty directly into the right atrium. Compared to the other larger cardiac veins, the anterior cardiac veins are unique because they do not coalesce into the coronary sinus. The great cardiac vein courses in the anterior interventricular sulcus along with the left anterior descending artery. Here again is the coronary sinus, which empties into the right atrium near the entrance of the inferior vena cava. The middle cardiac vein accompanies the posterior interventricular artery within the posterior interventricular groove, or sulcus. And the small cardiac vein courses in close proximity to the marginal artery, which supplies the right heart margin. Notice how both the middle cardiac vein and the small cardiac vein drain into the coronary sinus, which drains directly into the right atrium. So how can you remember which arteries are paired with which veins? Well, think about it logically. Of the three arteries we've discussed, which is the most important? The answer is the LAD. The left anterior descending artery is most important because it supplies the anterior 2/3 of the interventricular septum, and it also supplies the anterior walls of both the left and the right ventricles. If the anterior interventricular artery, aka the LAD, becomes occluded, then blood flow to the left ventricle will be significantly reduced. As a consequence, the left ventricle will have a hard time contracting and will have a hard time pushing blood through the aorta into systemic circulation. So the LAD is the most important. No wonder it's called the widowmaker. What artery would be the second most important artery? The answer is the posterior interventricular artery because it supplies the posterior 1/3 of the interventricular septum, and it supplies the atrioventricular node, which is important for the conduction system of the heart. And then lastly, the least important of the arteries we've discussed would be the marginal artery. This artery runs along the right heart margin, and it only supplies the right ventricle. As a reminder, the right ventricle is much weaker than the left ventricle because the walls of the right ventricle are much thinner. It can be weaker because it only has to push blood to the neighboring lungs. So the ordering from most important to least important is the LAD, posterior interventricular artery, and the marginal artery. So now all you have to do is pair up the cardiac veins from greatest to least. For example, the great cardiac vein will be associated with the most important artery. The middle cardiac vein is associated with the second most important artery. And lastly, the small cardiac vein will accompany the artery of least importance, which in this case is the marginal artery. Thanks again for listening. Before signing off, I want to point out that there are a few additional self-study materials. Of these self-study materials, the ones that would be most pertinent and relevant to look at before your case session would be the CT images of the heart. So please take a look at those. Happy studying!